Choosing the right hospital is as important as choosing the right doctor, not just for its patient's experience and safety score, but also for the use of technology, which improves patient safety by reducing medication errors, minimizing adverse drug reactions, and ensuring compliance with practice guidelines while improving the quality of life. We are now at CVSKL to see the hospital's use of technology and high-tech equipment, especially their Electrophysiology EP lab. Before that, I'm going to get someone who is well-versed with this place and also with what he practices. We have Datuk Dr. Razali Omar joining us today. Hi, Dr. Razali.
Hey, hi Amanda. Welcome to CVSKL.
Hi.
You're just in time. We're just about to do a very complex case.
Oh, wow.
Shall I bring you to the EP lab?
Yes, please.
Please, come. Let's go.
So thank you so much, Doctor, for being here with us today. I have quite a few questions, so let's begin.
I'm very excited. Let's go.
Okay, so I heard that CVSKL has one of the very few dedicated EP labs in the country. Is that true?
Okay, I have to be very careful about answering this question. It's very I have to be politically correct.
Okay.
So yes, indeed, amongst the private hospitals in the country, I think we are the only hospital in the country with a dedicated EP lab.
Wow.
And I just want to clarify for the audience, it does not mean the other private hospitals do not have EP facilities. So that's the difference.
Yep.
So most of them have a combined lab where the interventional cardiologists, they do stenting, they do other procedures, and on days that the EP doctors will come in, so that lab becomes an EP lab.
Okay.
But when we first started CVSKL in 2017, we have decided that EP is, and I think we were right, EP was going to explode, and we purposely dedicated one EP lab, and this lab is a dedicated EP lab, and only designed for doing EP related cases. So it may not be politically correct, but absolutely right.
Fantastic. So let's get into what an electrophysiologist do. What do they do?
Okay, so this is a very frequently asked question amongst patients, because patients will say, my cardiologist asked me to see you. As far as I know, you're also a cardiologist. So I usually explain to them in terms of plumbers and electricians. So I say your doctor, and most of the cardiologists in the country, I would say about maybe 90-95%, they are specialized in things like the coronary arteries, heart failure. But when there is an electrical abnormality called arrhythmias, then the doctors usually will send to subspecialties like me. And we are called electric physiologists, the physiology of the heart. So we are a sub-specialty, or in Cantonese called sub-soy, and we deal with electrical abnormalities of the heart.
Definitely not sorry. Definitely not. Now, the next question I have is, what causes a fib?
Atrial fibrillation.
Okay, so what's the short form of it? Okay.
AF.
AF. Okay, so what causes AF? Is it caused by genetics? Is it caused by medications took in the past?
Right.
Or is it high blood pressure? These are some of the questions that are posed by the audiences online.
Okay.
Yeah.
So atrial fibrillation, the word atrial fibrillation means the arrhythmia, the abnormality, is originating in the atrium. As you know, the heart has got 4 chambers.
Yes.
The 2 on top is called the atria, both right and left, and the 2 at the bottom is called the ventricle. So when an arrhythmia, when an abnormality originates from the atrium, it will be called atrial something. So when it's fibrillating, it's called atrial fibrillation. The other arrhythmias that originates from the upper chambers are atrial flutters, atrial tachycardias, supraventricular tachycardias, and so on and so forth. If it originates from the ventricle, it's called ventricular tachycardia and ventricular fibrillation.
Okay.
So first, the word means it designates which chamber, in this case atrium, and the fibrillation is what sort of arrhythmia is this? Is this fibrillating arrhythmia? Is this fluttering arrhythmia? Or is this tachycardic arrhythmia? So the word atrial fibrillation is, or the short form AF, is the commonest arrhythmias, and in fact it represents about 80% of the new referrals that I see in my clinic, and this is actually an explosion. We are not only facing COVID pandemic, but the atrial fibrillation pandemic superseded the COVID.
Oh my.
Yes, and this has been shown not only in Malaysia but all over the world.
Wow.
It is estimated that in China, for example, and this was a study that was recently published, that by 2050, which is about maybe 20 or 30 years from now, we are going to see at least 10 to 15 million people suffering from atrial fibrillation.
Oh my.
So usually people ask me, what is the incidence or prevalence of atrial fibrillation in Malaysia? It's around the region of about 1% of the population. So about 30 million people. Now it's 35 million. Roughly 1% of that would have atrial fibrillation.
All right. So, what is actually the cause of it? What's the cause of it? Genetics?
Traditionally, it is an aging arrhythmia. Meaning that as we grow older, then the heart and all our body undergo degeneration.
Yes, of course.
The knees go weaker and you get arthritis. So the heart also undergoes degeneration, and atrial fibrillation is a common arrhythmia as we grow older. This has been the concept that I grew up with.
Yep.
However, over the last 5 years, this concept has been thrown out of the window.
Oh.
Because now I see, and this is a bit problematic, because I see young patients. Patients that 10 years ago I do not see with atrial fibrillation. I'm seeing 40, 50-year-old with no other medical problems, and yet they present with atrial fibrillation. And worse still, they are usually not symptomatic. They don't know they have atrial fibrillation because they are young, and they are so busy with their work. They think that, the heart is fast a bit, maybe I'm too stressed out,
Yes.
I'm tired, I don't have enough rest. And a lot of patients, sometimes they come in as a complication of an atrial fibrillation which has left undiagnosed and untreated. Some of them present with heart failure, and some of them present with stroke. It's only after the events such as stroke or heart failure, then the doctors realize that they have atrial fibrillation and no other reason apart from atrial fibrillation, and that's very worrying. The traditional cause, as I said, was aging, but anything that causes stiffness of the left ventricle. So the principle is anything that causes stiffness of the left ventricle, because the whole cardiovascular system is a complete circle, which means there is no end or there is no beginning. It's all connected. So if the left ventricle is stiff, what causes the stiffness of the left ventricle? Coronary artery disease, patient with heart attack and heart failure, hypertension, diabetes, sleep apnea syndrome, obesity, anything that leads to the condition where the left ventricle becomes stiff, that means the left atrium becomes stretched out. When the left atrium becomes stretched out, it will trigger the atrial fibrillation. So there are many causes. Those are the traditional causes. Then there are causes in which it is like triggered by something which is not permanent. For example, a young lady may get thyrotoxicosis. When they have thyrotoxicosis, then they can get atrial fibrillation. But that atrial fibrillation is related to the disease. And once the disease is treated, the atrial fibrillation goes away. The one that we mentioned just now, aging, hypertension, diabetes, is not going to go away. The other thing is sometimes infection. When you have infection, very bad infection, it can lead to some form of carditis. You can get atrial fibrillation. Alcohol, for example. So there's a lot of stories like people, like in the UK, for example, they call it, like alcoholic heart syndrome. They go for holiday, and then suddenly they drink a lot because they are on holiday. And all these young people, they visit the emergency room because they go into atrial fibrillation. So these are called reversible causes of atrial fibrillation. And these are usually, once you identify the trigger, you tell them to stop alcohol, you treat the thyrotoxicosis, you treat the infection, they usually get better.
So many different triggers actually, right?
Many triggers, yes.
But you did not mention genetics because that's what some people think.
Correct. So previously there was no relationship of hereditary or familial form of atrial fibrillation. Recently there has been some reports. Extremely rare. However, these are in a group of family members, but they usually present in the young. So, brothers, sisters and all that have atrial fibrillation at the age of 12, 13, 14. These are extremely rare. In my own experience, I have been doing this for nearly 30 years, I've not seen anyone with familial or hereditary form of atrial fibrillation.
Okay. Now, what can someone expect on their first visit to an electrophysiologist? Okay,
so usually electrophysiologists, we don't see patient that walks in. So we are what we call quaternary referral. So you have the first liner like GPs, family physicians, And then if they find something not right, they will refer to either internal physician or they refer to cardiologist.
Yep.
And then the cardiologist will assess and find that, oh, this patient has atrial fibrillation, and then they might see it fit then to refer to an electrophysiologist. So usually by the time I see a patient, the patient, thanks to all my colleagues, has been fully investigated.
Yep.
You know, so I don't really have to do a lot of other things. So they come to see me because my colleagues have already put it in a nice bundle and say, here you go, Razali. This patient I have investigated, his coronaries are not a problem, he doesn't have hypertension, diabetes, and all I think he's got atrial fibrillation. Maybe you should see him and discuss treatment options. So when I see the patient, a lot of the time, my job is like this. I will discuss and spend maybe 30 minutes, 45 minutes to talk to the patient about all the option strategies, what are the things that can happen if you don't treat stroke, heart failure, poor effort tolerance, poor exercise performance. Give them all the therapeutic options that's available, such as stroke prevention, drug therapy, catheter ablation, and so on and so forth.
All right. Wow. Okay. Thank you so much, doctor. Now, so basically, the first visit to an electrophysiologist, it's when they have already gone through all those steps.
Most of the time, yes.
Yep. All right. Now, what is an electrophysiology or the EP lab?
Right. So we are
now
sitting in the EP lab.
Yes.
The EP lab is like a cardiac catheterization lab.
Yep.
We call it cath lab. The short form is like, where are you going? I'm going to the cath lab. CATH, cath lab. So it means the cardiac catheterization lab. Catheterization simply means that we are just putting catheters through the patient's vascular system. In our situation, it can either go from the femoral, the groin, or for my colleagues who do angioplasty, now go to the wrist, called the radial artery. So in this lab, it is equipped with the ability for us to gather information that is electrically, all the electrical signals that's coming from the heart. So the patient will be sitting on this table. This is an X-ray machine, and what you can see there, that is a 3D machine. So I had a young visitor, a young student who wants to venture out into medical school. So nowadays they don't just because you have 20 A's you become a doctor. No, you have to have the passion.
Yes.
You have to know what you're doing. So they come and visit us, and then I was telling him, I say, I'm sure you're a gamer, and what you see them is actually me playing a video game. So now a lot of things are doing like if you see this 3D in action, we are actually like playing a video game inside the heart. So a lot of things in the EP lab is actually related to how we try and cure the patient's arrhythmias.
All right. Thank you, doctor. So this one is a little bit more in-depth. How do you decide on the procedure such as the maze procedure, catheter ablation, or a pacemaker?
Right. So that's a very interesting question, and that is the first visit.
Yes.
In the clinics.
Okay.
So I will go through and ascertain whether the patient's atrial fibrillation, if the atrial fibrillation is chronic, the patient is elderly, and the patient's atrial fibrillation is very, very slow, such that his symptoms are related to fainting, blackouts, then this patient will probably need a pacemaker.
Okay.
But if it's a younger patient whose problem is not slow heartbeat, but the atrial fibrillation is causing him a lot of symptoms, and he has been tried on medications and it did not work, then we will explore with him the catheter ablation option. This is to try and cure his atrial fibrillation.
Okay.
So, and this concept of catheter ablation to cure atrial fibrillation started about 20 years ago. So we have been doing this for the last 20 years. And I think we are getting better and better at this. And what I mean by that, 20 years ago when we first started, the chance of a patient getting cured after one procedure is probably 50%.
Okay.
So we would try and 2, 3, 4 medication until we run out of all the medication. We said, maybe you can try this option. But 20 years down the road, a lot of experience, not only from the doctor's side, but the equipment has been so advanced that it becomes safer now, such that we now offer this catheter ablation, especially in the young patient, as a first line. which means that we said you may not want to take medicine. Even if you do take medicine, it's like you are investing in a very poor investment, because at the end of 10 years, you spend money paying for these drugs. At the end of 10 years, the atrial fibrillation say, I've not gone away, I'm here. So let's go for some treatment that can cure your atrial fibrillation. And now we have evidence that the earlier we do it, the much better. And just, I usually tell my patients, it's like you grow some, you plant a small little plant, and then Amanda comes in and says, I don't like this plant. I can just pull it out, throw it away. But 10 years later, Amanda says, I don't like this plant. I said, Amanda, you have to live with it. The roots are 10 feet deep. Even if I were to cut this tree, the roots are still there. So this is the concept of atrial fibrillation. Atrial fibrillation begets atrial fibrillation. If you leave atrial fibrillation and let it run wild in your heart, and then you go for treatment, the chances are you may need more than one procedure. So all this will be discussed with the patient. That's why it takes about 30 minutes to 45 minutes.
One more procedure was the maze procedure.
The maze procedure is a surgical procedure. So I don't do maze procedure. So if you have time, the history of atrial fibrillation started with the maze procedure. It was by a surgeon in the United States called Professor Jamie Cox. And he started doing maze procedure where he opens up the heart and he chopped the heart into small pieces and then he stitched them back. And then he found that, voila, no atrial fibrillation. Unfortunately, apart from his hand, no other surgeons can replicate this. So it is a very, very, very invasive procedure. It took the cardiologist, just like anything else, like in medicine, from CABG become angioplasty. It took us to realize that we can actually try to replicate this, but in a different way. So the maze procedure was the father of atrial fibrillation, but over the years we have tried to modify it, and now it's something like the maze procedure, but it's done in a or minimally invasive way, just like playing video games. You don't have to chop up the heart. And blender it.
Not in 2022.
No. Nobody does maze procedure anymore.
Okay, got it. So how do you choose a good candidate for catheter ablation?
As I mentioned, if the patient is... So we look at it, but atrial fibrillation can manifest in different ways.
Yes.
If the atrial fibrillation manifests as mainly the fast heart rate manifestation, then catheter ablation is one of the options that we will discuss with the patient. So as I say, each individual patient we will assess individually. We look at what are your comorbidities. For example, if the patient is young, but the patient has got heart failure, kidney failure, one leg gone, one arm gone, one head gone.
One head
gone, so maybe one head gone is dead. But what I'm saying is that if the patient has got a lot of comorbidities, then we say maybe for you, catheter ablation may not be ideal because the risk may be higher. But if I see a patient who's young, 50 years old, who is disturbed, his life is disturbed, he cannot go jogging, he cannot play squash, he cannot play tennis. He said, every time I go out, I get atrial fibrillation, I visit the emergency room. That's not on. He's only 50 years old. So we said, you can either take medications, which is a good option, but trust me, all the young guys, even if you give them medicine, they can take it for 1 week, 2 weeks, then they will all forget to take medicine. All of us do the same. This is the non-compliance. It's one of the problems that we face, non-compliance. You cannot expect somebody who's 50 years old to take medicine for the rest of his life. And if he lives as long as 90 years old, it doesn't make sense. So definitely catheter ablation, as I said, the history, the evolution of catheter ablation. 20 years ago, I probably will tell you to take drug A, drug B, drug C, drug D. But 2022, I will tell you, consider catheter ablation as your first line, even without trying out any medication. But this is a discussion between the doctor and the patient. If I'm doing this for the first time, then of course, I cannot quote other people's data. I cannot say, well, AF ablation success rate is 90%. 90% is success rate in another hospital. What's your success rate? What's your complication rate? This has to be factored in, and you tell the patient, you be honest with the patient. Like in my hands, so probably I would rather not do you. I would rather give you medication because your AF is a bit more complicated. But somebody who is used to doing atrial fibrillation ablation, then for him, maybe he says, in my experience, the catheter ablation, these are the numbers, these are the complication rates, these are the risks, and these are the success.
All right. Thank you, doctor. So
Welcome.
you talk a little bit about like the video game part of
Yes.
things.
Yes.
So obviously we're
So
using...
my advice to all mothers, parents, let your children play video game. They will become good like me. It's eye-hand coordination. Play PlayStation 5. Buy a PlayStation 5.
Oh my, okay. So we were talking about that video game part of things where it's 3D mapping, right?
Yes.
Is that basically it?
Yes.
Can you talk to the audience a little bit more about, how the technology has advanced and your experience using it?
Right. So we started using 3D mapping since 1999. So when we first started doing catheter ablation in Malaysia, it started in 1991, 1992. Initially at the Cardiology Department, Hospital Kuala Lumpur. Then the government gave us Institut Jantung Negara,
Yes,
Mahathir,
Andrea.
Dr. Mahathir, thank you very much. And then 1991, 1992, EP services started in the country. And for the first 10 years, it was just, we call it 2D. 2D means just use this machine, X-ray machine.
Yeah.
So the 3D was in our head. So we see 2D, but we imagine 3D. But as we do more and more complicated, like mace procedure, becoming catheter ablation, 2D no longer works. Because no matter how smart we are, our brain just is limited. So we need technology to help us.
Yes.
Because it is important in terms of safety. So I always tell my patient, above everything else, my job is to ensure safety during the procedure. The success comes second. I don't put success as first, because if you have complication, point of no return.
Yes.
If I damage your heart, point of no return.
Yeah.
But if you have atrial fibrillation that comes back, we can always go back in again.
Yes.
So this 3D technology has helped us to become more safe, because now we can map your heart accurately.
Yes.
I can go to the place that I want to go accurately, and I can deliver the energy effectively and safely.
Thank
That's
goodness
it.
for that 3D mapping. Fantastic.
Yes.
Now, can you tell us about something called implantable devices that are available in EP labs? I know off screen we talk about two, so maybe you can share with the
So
audience.
implantable devices simply means that anything that we implant in the human heart, in a human body. And the most common and most people would be familiar with is a pacemaker.
Yes.
So a pacemaker is when somebody's heartbeat is very slow. It usually happens in people who are older, and it's part of aging. And they might have fainting episodes. You might have dizzy spells. And once we determine that they actually have slow heartbeat, we implant a pacemaker. Traditionally, the pacemaker is what we call transvenous system. A small surgery, we put 2 wires inside the heart, and the battery is buried under the skin.
Yes.
Nowadays, over the last nearly 10 years, I think, we have the latest technology, which is called the leadless.
Yes.
And how I tell my patient is that, in life, you don't like the middleman. But the technology previously was not good enough for us to deliver the pacing into your heart. So we have to have the wires. The wires acts as our middleman.
Yeah.
If you can get rid of the middleman, once we get rid of the middleman, then it's much better. So the leadless pacemaker gets rid of the middleman, called the wires, the leads, and we now put in. In fact, after this interview, I'm going to do one leadless pacemaker. So that's pacemaker for slow heartbeat or bradycardia. The other implantable devices is on the other end of the spectrum, and this is called the implantable defibrillator. Who are these patients? The most famous now is during the, I think, European Cup, isn't it? Football. Remember a Danish player collapsed? He had a cardiac arrest, CPR, and would you believe it, he survived? They implanted an ICD, implantable cardioverter defibrillator, and he's now playing for a Premier League team in England, isn't it? Yes. So the ICD is a device that will give you an automatic electric shock when the heart stops. So it is opposite of pacemaker. Pacemaker, when the heartbeat is too slow, the pacemaker corrects that. When the heartbeat is too fast and you are at risk for cardiac arrest, And if you are in the hospital, then the doctor will go and CPR and shock externally.
Yes.
This device recognizes that you have a dangerous rhythm and delivers the shock automatically, and then it saves your life. So the ICD is, and the third device that we implant, implantable device, is for heart failure patients with risk of sudden death and dysynchrony. So we put 3 wires and we synchronize the left and right ventricle. So there are a lot of implantable devices ranging from a simple pacemaker, leadless versus traditional, ICD, single dual chamber, and of course the heart failure triple chamber ICD pacemaker.
So interesting. Thank you so much, Doctor. I feel like I'm learning so much. I should have had a pen and paper to write down some notes. Very, very interesting talk we've had so far. Now, we also want to ask, what are some of the successful milestones that CVSKL has managed to achieve in the electrophysiology department, your department basically?
Right. So, I mean, when I came to CVSKL in 2017, I was already in IJN for the last 25 years. So there was a lot of milestone that we already achieved. And we brought back all those experience, all those technology when I started practicing in CVSKL. But what has happened since I started in CVSKL? Well, the good thing is that we also brought in some research. So as you know, most private hospitals, they don't get involved in research. But CVSKL is unique in the sense that, at least when I'm here, I myself have gotten involved in 2 of the worldwide registry. One is for cryo balloon ablation.
Okay.
This is another way of doing ablation for atrial fibrillation. Instead of using 3D map, instead of using radio frequency, we freeze the heart using nitrogen oxide.
Okay.
So because of the work that we did with cryo balloon in the country, I was asked to continue with the delivering with the research cryo, and we've just finished that together with Medtronic. We also did Micra. Okay. The Micra is also part of our research thing, and again, this is a testimony to our experience and our involvement with this technology. The other thing that I must say is that most of us, once we go to private hospital, we stop teaching junior doctors, because we are all alone in this private hospital. We are so busy. But I have started doing a fellowship program where we invite doctors, young electrophysiologists. They are not young doctors, they are young electrophysiologists to our hospital to spend 2 days with me, where I show them how we perform atrial fibrillation ablation, so that we can try and continue to share our experience and our knowledge for the future of the country's electrophysiology community. So
That's
these are some of the
amazing.
milestones.
That's amazing. I really think that's amazing, because, like you said, you're all alone in the private hospital, for example.
Yeah.
No one there. So I think that's great work that you guys are doing, even
Thank
that
you.
add-on. I don't think we have any more questions left. So thank you so much, Doctor, for
My
your
pleasure,
time
my
for
pleasure.
today.
Thank you very much, Amanda.
Thank you very much, Doctor. It's impossible to truly appreciate the current state of healthcare technology in our country without reflecting on how far we've come. If you've recently learned that you need to enter a hospital for surgery or another reason, your main focus should be to get the best care possible with the best facilities. I'm Andrea, signing off. See you again next time.